Thanks, Tom. I think I'm going to ask Tim Cromwell to comment. I know the VA is such a leader in this area. Tim, do you want to make a few comments on patient engagement?
Sure, Kate. Thanks for the opportunity. One of the things I didn't mention is in VHA, we also have a very robust personal health record. It's called My Healthy Vet. We do in-person authentication to get the signature for the first time by veterans to be able to do certain things like secure messaging over the personal health record. We have a lot of contact with our veterans, and we're very confident that veterans want us to move toward health information exchange and interoperability with the private sector. We hear it anecdotally. We hear it, in a lot of different ways that veterans and veteran service organizations and groups want us to pursue. And because we are contacting every veteran, eventually we'll contact all 6 million of them to ask if they want to share their information with the Nationwide Health Information Network. We really have a very good relationship with our stakeholders, with veterans, with the veteran service organizations, in trying to get a sense of what they want us to do and what priorities. So in this particular project, in engagement with the Nationwide Health Information Network, in the pilots, we've already engaged in almost all of those 11 locations, a letter that goes out to the veteran explaining what it is we're asking them to do, sign this authorization. We've gotten some really good response rates from veterans who indicate that they're in favor of it. And just one very brief anecdote, our first pilot was in the San Diego area with Kaiser Permanente, and we sent out these authorization letters, the cover letters, and the authorization form asking for their signature on the day after Thanksgiving, and by Monday morning we had 100 of them back already. And so in certain markets and areas, we know that veterans want this, and that's, as I've said, that's pretty much our driver from our stakeholders to make this happen.
Thanks, Tim. I'm just going to ask for volunteers. Does anyone want to just comment on patient engagement?
Ted in Rochester, I think it's been very helpful for us. Again, we have two lines of business where we really had two sets of customers in some ways. We needed that patient to feel comfortable with providing consent to their physicians. So we early on engaged all our community PR people from the hospitals and created article banks and ad banks and did all household mailings and theater spots. And it's really helped, because otherwise physicians were very concerned that bringing patients up to understanding why they should participate in an HIE was going to sort of look like a long, uncompensated conversation. So I think it's absolutely critical, and there's creative ways to do it with your participants.
Thank you. Oh, Russ, go ahead.
Yeah, Kate, I was actually hoping you wouldn't call on me, and then as I sat here, I wanted to say something. So that's the risk you run. But just a couple of observations about this question. One, where we see a lot more patient engagement, and we talk about member engagement, right? Because if you think about our business, our primary constituents are health plans and physicians, yet they are serving patients, are serving members, insured members. And through our network, we have roughly 100 million members that are served through physicians and health plans on our network. A couple of areas where we're seeing increased activity, right? So one is around the kinds of information that a patient needs to make a medical decision, right? So content, and health plans particularly trying to find ways to drive, patient-relevant content out to their members, condition-specific, disease-specific types of information. And then the other is around the financing side. Patient-centered medical home comes at the same time that you're seeing tremendous growth in high-deductible health plans, consumer-driven health plans. And one of the big challenges with those is providing transparency to us as consumers of healthcare around cost and quality, and where the alignment between those two exists. And so where we're being, I think, sort of uniquely challenged is to help our stakeholders, both physicians and health plans, drive that kind of transparency out to members so that, at the point of service and hopefully even in advance of the point of service, you're helping to drive educated decisions around healthcare. So just at a very rudimentary level, one of the capabilities that we've enabled for our physicians and where we're seeing tremendous growth of activity is real-time member estimation and payment for services. So, we know from the data that if a patient walks out the door without paying for their share of it, the shrink rate, the loss rate is 60%. On those dollars. And when that's a $10 copay walking out the door, it's not that big a deal. When it's a $200 member responsibility walking out the door 20 times a day, that adds up quickly. And so we're seeing both on the physician side, the plan side, as well as the patient side, a real interest in getting that information at the point of service because, just as physicians don't want to have to go collect all of this money, patients really don't want to be bothered with it and get bills for months at a time and try to figure out exactly how much they owe and what the health plan is going to cover. So just as with our core business and serving the administrative needs of physicians and a real demand for more information around eligibility and how are claims processed and the basics, we're seeing a significantly growing interest in more member transparency and information around, frankly, from a physician perspective, how to interact with their patients from a financial perspective.
Thank you. So, we're kind of getting short on time, so I'm going to offer up one last sort of wrap-up question and try to call on as many of you as we can to get your words of wisdom. But this is a fabulous conversation. I know we'll have, we're going to make sure we have more opportunities to discuss. But so the wrap-up question is, if you had one opportunity, one word of advice to others who are, at an earlier stage in building their health information exchange organizations, what would that one, word of advice be? And I think I think I'll start with Alan from Big Bend.
Well, I think you quoted my word of advice in the press release, and that's basically keep going. It's most of us around the table, I would opine, largely do this out of passion to make change. And it's not about the money. It's about making a difference. And it is difficult, and it's going to be difficult for some time as we try to transition an industry of status quo into and across the digital age. But I've certainly wanted to walk away 3 or 4 or 5 times the last 6 years, but because we're now making some significant progress, we can see the change, we can see the benefit, we can see the adoption and the utilization. We are affecting positive change and saving lives. So keep going, and I actually can't take ownership of I'm saving lives. It was an ER physician that's a friend of mine when I was about to throw in the towel 4 years ago, looked at me very casually and said, "But you're saving lives." And, of course, my response was, "Don't do that to me." So keep it up and stick with it. We will get there.
Michael Matthews, how about you?
Well, thanks, Kate. It's been a good session. My advice would be to keep the focus on the patients, particularly the most vulnerable patients, the ones I mentioned in my remarks, the chronically ill, the emergency patients, wounded warriors, and the disabled. We have to get to a point in this country where health information exchange is viewed as a standard of care and not as something discretionary and optional. If we can get to that point, we'll figure out all the ways of sustainability and some of the other challenges that HIEs across the country have faced. Thank you.
Mark Jones?
Kate, thank you. I think I'd reiterate some of what our partners have said today, which is that starting at the bottom with the physician and the patient, focusing on that and trying to build your system up from the bottom is the key to success. I think we're seeing a lot of efforts around the country now at state levels where they're essentially starting at a very high level and trying to work down. And I hope that all of us here have active conversations with those groups so that the realities of what need to happen are reflected into the decision-making processes that they're going through right now.
Kimberly, how about you?
I think being sensitive to the different phases that organizations are at right now is really important, and to have product and service offerings that can meet those needs. Everyone's at radically different phases of EMR adoption, which is, kind of a base level that you need to be at. And I think, being open to offering the services. There are a lot of organizations that do not have the resources to do a lot of this. I think, being prepared to offer some of those services would be really crucial.
Keith Hepp?
This is our moonshot in healthcare IT. So there's significant funding that's out there in order to become electronic, and but very quickly it's going to go from lots of funds out there in order to build the infrastructure to how it's going to be sustained. So it is very hard work at the beginning to get a sense as to who's going to pay for what and why would they pay for it. But as you build your infrastructure, it's critical that you have a key understanding of the unique nature of who is participating in your exchange, who may participate in your exchange, and that when you build your infrastructure, that you don't build in such a way that initial participants are getting a sufficient value, but long-term they do not get enough participation to get the value, so that you have tail costs, which will be very difficult to maintain. So starting off with a good plan, which involves a good understanding of what the economics of each of the different components of an exchange are, is critical to surviving past just the days of ARA.
John Blair, I'm going to give you the last word of wisdom.
Okay, so this is about HIEs and sustainability, right? So I think there's a couple of ways to look at this. If this is a community effort, then I think critical is leadership, and particularly outside of IDNs, and I think it's leadership and being able to galvanize a governance structure to drive that interest and ultimately build up HIE, et cetera. If it's really a business proposition, looking at what's going to happen with technology infrastructure across the country, clearly a lot of money has been put behind EHRs, and if it's successful, they should be fairly ubiquitous. And I think then there becomes a strategy of connecting those systems in a meaningful way clinically, and that's a different thing than the first thing I just said.
Okay, well, thank you so much. We are out of time, but I want to thank our HIE leaders for participating in this project, for participating in this discussion today. This is just the beginning of a lot more to follow. As I said earlier, NEHC will be releasing the report very, very soon, and we will also be building on the findings to do additional programs like this, both live programs and roundtable discussions, as well as web-based education programs that will both look at the case studies of these organizations, the critical success factors, go deeper on some of the remaining ongoing challenges out there, and try to come up with solutions to overcome them. So thank you so much, and thank you all for participating. This concludes the program.
The caller has left the conference. The caller has left the conference. The caller,
Alan Byington, Big Ben Rio,
has left the conference. The caller 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 has left the conference. The caller, Kevin Stevens, has left the conference.